Welcome to the Medicine and Science podcast from the BMJ. I'm Cameron Abbasi, Editor-in-Chief. This week on the podcast, the BMJ investigates Q-collar, an American device that distributors claim can reduce brain injury from contact sports.
What else lurks beneath that we haven't noticed? If somebody made, let's call it an innocent error, if they made an innocent error for one of the key pieces of data, what else is there that's also an error that we're not noticing?
We report on the research to discover the best exercise options for osteoarthritis.
I always told my patients surgery would be my last choice to treat the knee OA.
And what patients really think about patient choice.
So it's not a magic fix. Yes, I chose that. It is more convenient, probably on balance, but it does have drawbacks. And there's no in between. And I think that's what we miss often, and it's the same with self-management. We talk about self-management, patient choice. They're all the kind of same slogans, but that often ends up with patients kind of being left on their own. Like, oh, you just manage your condition by yourself.
Firstly, the Q-collar is a simple device making big claims that it can reduce brain injuries from contact sport. It's been getting traction in North America in recent years with amateur and professional athletes, especially for NFL, that's the National Football League, and lacrosse. Imagine a horseshoe-shaped collar made of plastic and metal which sits around the neck and applies a constant pressure to the jugular veins. Its inventors claim it can increase blood pressure to the brain, reducing sloshing when athletes take big knocks. The studies that are claimed to support the benefits of Q-collar are a big part of its marketing. But does that evidence hold up under scrutiny? Our new investigation into Q-collar is just published, and Peter Doshi, an editor in our investigations unit, finds out more.
Being an athlete that's played contact sports for as long as I have, you become aware of the repercussions of bashing your head into another person or, concussion-like syndromes that can come from these contact sports. You're looking for ways to reduce that impact. Any other way you would do it when it comes to, soft tissue injuries? What are the preventive measures you can take?
That's Johnny Townsend, a former professional American football player in the NFL and a current member of the U.S. bobsled team.
And so when Q-collar came about, it was, wow, here's an actual device that can help prevent concussions. And, seeing all the science that was behind it, reinforcing, their claims on how it can support athletes, wanted to try it.
Johnny is talking about Q-collar, a wearable device that in 2021 became the first and only FDA-cleared product to protect the brain in contact sports. And Q30, the company behind the Q-collar, claims there's a lot of science to back the product. The device is shaped like a horseshoe with a rigid metal and plastic frame that applies a light pressure to the sides of the neck, restricting blood flow through the jugular veins. For a price tag of $200, Q30 claims that this interruption of blood flow can increase blood volume in the brain. This would, they say, reduce the damaging sloshing of the brain that follows when an athlete takes an especially hard knock. But the Q-collar story doesn't start with athletes on the field. The device's inventor says the story actually began with the humble woodpecker. Let's listen to an advert from Q30, posted in 2021.
Conventional thinking to solve the brain injury epidemic in sports has been focused on protection from the outside. A team of doctors came together with a different idea, to look for the solution from inside the body. They studied the evolution of animals whose very means of survival is to hit their heads. Nature reveals that the prevention of brain injury comes from the prevention of brain movement. But how to achieve this in humans? Their research indicated that by manipulating the body's blood flow, you can create a tighter fit for the brain inside the skull. They put their idea to the test in the lab. This initial study showed that jugular compression reduced torn fibers in the brain by more than 80%. With this groundbreaking research, the innovators turned their focus to partnering with a team to develop an externally worn device that could help reduce the brain's movement safely and comfortably. Q30 and the Q-collar were born. 6 years, more than 20 studies, and over 1,000 participants later, research has consistently shown the Q-collar helps protect the brain from sports-related impacts.
The BMJ was approached last year by a professor who studies sports injury prevention, who was saying that the data behind the Q color was not reliable.
The unfortunate part of that is that there's no evidence that woodpeckers actually utilize this mechanism to protect their brains. I'm James Smoliga, and I am a professor at Tufts University School of Medicine within the Department of Rehabilitation Sciences. I work in the field of sports injury prevention and rehabilitation and sports performance optimization. The woodpeckers have been extensively studied, including since the 1970s. There's a paper published in the Lancet about how do woodpeckers protect their brain, and there's been a lot of work done by ornithologists and engineers and physicians since then trying to figure out how woodpeckers protect their brains. And basically, jugular compression isn't one of those mechanisms.
James first got interested in the Q collar after reading a paper, co-authored by the device's inventor, which stated that athletes experience fewer concussions at higher altitudes. The paper speculated that increased blood flow at higher altitudes could lead to a tighter fit around the brain.
I walked in my office one day and a colleague said to me, there's a new paper that just came out that said that the risk of concussion is lower at high altitudes. And I said, oh, that's interesting. How high of the altitude? And he said 600 feet above sea level. I said, well, no, that can't be right. 600 feet above sea level isn't enough to make any physiologic difference on, the brain.
It started with the altitude paper, but over the next few years, James began to catalog many problems with the science underlying Q collar, and he's managed to get other scientists interested. Most recently, he's been working with Yang, a behavioral neuroscientist from Columbia University.
I am a scientist at Columbia University, but the reason why I'm here is because I'm a sleuth. Sleuth is basically a science detective. So I have caused over 200 papers to be retracted.
James asked to look at some of the Q collar papers that have been published in the Journal of Neurotrauma. Two papers in particular caught Mu's attention. One study presented results of Q collar in around 70 female high school soccer players. The other paper was of 23 male SWAT team members, but the two papers presented the same data.
I think on the second day, I text Jamie and I said, you owe me a beer. And he's like, what? And I showed him two tables from two papers. They contain absolutely identical data. And then if you look at the figure legend, you see that the description of the subject are completely different.
Yeah, essentially two different tables with basically slightly different headers. The soccer study said preseason, postseason. The SWAT study said pre-training, post-training. The number of subjects differed within the table between groups, but yet all 96 cells of data were exactly identical. Some cells went to 3 decimal points, and all 3 decimal points were identical. There's no way that was coincidence. And there's the only explanation was that they copied and pasted the table, updated all the headers and all the subject numbers and changed, everything in the columns and rows, but then somehow forgot to update the most important part, the actual data, which is, in my opinion, kind of a ridiculous explanation. And the way I like to think about it is, regardless of intention, we can't trust this. And, which one of these is the real table? Which image is the right image? And what else lurks beneath that we haven't noticed? If somebody made, let's call it an innocent error, if they made an innocent error for one of the key pieces of data or one of the key images, what else is there that's also an error that we're not noticing? So regardless of intention, when we see objective evidence like this, we can't trust any of it, in my opinion.
We contacted the journal that published these studies, and they told us that it would publish James and Mu's letter documenting their concerns as well as responses from the authors once their investigation into the data anomalies had concluded. At this point in time, the journal has issued an expression of concern for 6 papers, noting their ongoing investigation. As part of this investigative work, the BMJ approached Greg Meyer, the lead author on the Q collar studies. In an email response sent to the BMJ, Meyer acknowledged what he characterized as, quote, minor reporting errors, and said that, quote, none of the raised issues altered the conclusions of the studies. He added that he remains committed to, quote, the highest standards of academic integrity and transparency, and will, quote, continue to correct any genuine errors. A full copy of their responses, as well as responses from Q30 and the Journal of Neurotrauma, are available on bmj.com. Now, NFL players are always looking for an edge on the field, something that lets them play harder and for longer. It's no wonder they look to science and technology to help them out, as Johnny Townsend, who we heard from at the beginning, explained to me.
Well, I think, helmet technology has come such a long ways. I have, two helmets behind me, two different generations of, NFL style helmets. I'll show them to you real quick while we're here. So this was a 2018, 2019 version of the Rydell Speed helmet. It was what we call just a bucket. The padding was pretty old school. It just has, air suspension systems within it. Chin strap hasn't changed very much, but helmet technology, even 2 years after, the Speed Flex version came out, and it has all of these different pads that help absorb, the shocks of helmet to helmet contact, contact with the ground. And so it's nice to know that equipment has kind of like really developed along the time I was playing, and you can notice, the health effects from it as well. When as an athlete, again, we're not scientists, so we don't really understand how data works. We just understand the cause and the effect. And one circumstance is by trying it and making the assessment for yourself. And then the second, side of things is just blindly trusting individuals that are scientists and those that do have, data to support their claims.
The scientific claims touted by Q30 led Johnny to try the Q color to see if it might work for him.
Didn't notice too much of a change, honestly, in the effects between one run versus the other. But I've, beyond that, wore it longer and longer to see if there was some sort of, trend I could notice in the effects. And unfortunately didn't pick up on too much. Some guys, I've talked to a lot of NFL guys as well that wear them because, part of my evaluation of whether or not I would continue using it was the feedback of peers that I trust and guys that have played contact sports also for a long time, but at more dangerous positions like running back, linebacker, offensive line. And, getting their feedback was important. And the majority that I got from them was pretty similar to my experience. Didn't really notice any positive or negative effect from wearing it, but they just chose to continue wearing it because, if it could potentially help, why not just wear it just in case?
One way a company can fortify its scientific credentials and obviously boost sales is to have the FDA authorize its product. This happened for Q30, the company that makes Q collar, in 2021. This surprised James and Mu, as they had seen these problems with the publicly available research on Q collar, and they wondered what data the company had provided to FDA to get such an authorization. So they requested those data via a Freedom of Information request. Hunting through the documents, they discovered that the FDA had also found numerous problems with the Q collar studies. It wasn't anywhere close to a glowing endorsement.
And so what the Freedom of Information Act to the FDA revealed, the documentation revealed, is the FDA wasn't convinced that this product actually was effective at protecting the brain. And so shortly before it got authorized, there were still people in the FDA saying, no, we don't believe that the methods are well enough designed to show effectiveness and the data don't demonstrate effectiveness.
The FDA is saying that the data they looked at does not show that the Q collar prevents concussion. But even more than that, the clinical meaningfulness of the kind of brain imaging the company was doing isn't clear. Despite these reservations about the science, James and Mu found that instead of rejecting the device, the FDA authorized it. The only caveat? FDA required that Q collar disclose the lack of evidence around the prevention of concussion into the fine print of the product's labeling, something few people are ever likely to notice. The FDA confirmed this in a response to the BMJ, stating that the clinical study data reviewed by the FDA, quote, supported the safety and effectiveness of this device as an aid in the protection of the brain from effects associated with repetitive subconcussive head impacts. The data do not demonstrate that the device can prevent concussion or serious brain injury. However, as you can see from this recent promotional video by the device's manufacturer, you never know the FDA had any doubts about the science.
Q collar is a non-invasive device worn around the neck. It's applying a very exacting amount of pressure, which allows for a backfilling. and there's more fluid being held in the brain, so the brain can't slosh or move inside the head. We reduce injury caused by repetitive subconcussive impacts. That could be what's going to minimize these longer-term health conditions, whether it's dementia, whether it's CTE.
Amazingly, the BMJ could not locate anywhere on the manufacturer's website the same caveats about the data that the FDA requires them to add to their owner's guide. And that can leave the target customer for Q-collar, people like Johnny Townsend, with the impression that the science on Q-collar is much more certain than it actually is. It turns out that if in the fine print essentially of the manual, like the user guide for the product, there's a sentence, I'll read it to you. Data do not demonstrate that the device can prevent concussion or serious head injury.
That goes against everything that they claim, right?
It is. It is sort of astonishing, and there's no additional sentences around it. It's just one bullet amongst a whole bunch on page, I forget, 10 of the 15-page manual or something like that. It's pretty astonishing.
People have this perception that if they wear this $200 piece of plastic and metal around their neck, that their brains are going to be safe. And it's a quick fix. And what we know, a lot of times quick fixes don't work.
So what I found really interesting about this story is that this is an area where there's this dire need for protection of the brain. People want to prevent concussions. And now there's this device that everybody thinks the FDA has authorized to prevent concussions. But when you look at the fine print, that core claim around concussions actually is not proven. And it's stated there in black and white. But who's going to have time to find the fine print? And so everybody's projecting this benefit onto the device, but when you look carefully, it's just not proven.
That investigation, how an FDA-cleared brain protection device built on shaky science made it to the NFL, is available online on bmj.com. Next, exercise can help people with knee osteoarthritis. But it's usually individual clinicians advising on which workouts are the safest and most effective. Well, new research might point us to the answer. Duncan Jarvis, our multimedia editor, spoke to Bin Wang from Zhejiang University School of Medicine, one of the authors of a new network meta-analysis of 160 trials investigating the best care plans for knee osteoarthritis.
Dr. Wang, could I get you to introduce yourself to our listeners, please?
Hello, everyone. My name is Bin Wang. I'm from China, Zhejiang University School of Medicine. I'm a surgeon from the Department of Orthopedic. My major is sports medicine.
So your question is really what exercise modality is most effective and safe for knee osteoarthritis. And we know that the evidence base for exercise is quite well established already. I mean, you had lots of studies in your meta-analysis. Why did you decide to do this research and come up with your research question?
Yes, from the two aspects. First, the clinical decision-making dilemma. We frequently encountered the patients in outpatient clinic asking, which exercise is most suitable for me? But existing guideline only broad mention exercise is beneficial without the priority recommendation for specific type. The doctor often have to rely on personal experience. Second, the number of newly published RCT trial have nearly doubled since 2019, but there has been no high-quality network meta-analysis to integrate this data.
If we go into a little bit of your methodology there, you looked at over 200 RCTs with ultimately about 15,000 patients in there. What were your inclusion and exclusion criteria for the studies that you wanted to include in your meta-analysis?
Inclusion. The RCT must report outcomes have to at least one of the following area: function, pain, quality of life, gait performance, and adverse events. Trials will exclude if they include patients who had a history of knee surgery or who had knee osteoarthritis and hip osteoarthritis at the same time. So we have to exclude them.
And it's interesting there that you included specifically safety data within this, because that's often not well documented in RCTs.
Yes, just as you mentioned, the number of RCT reported safety evidence is just 40 studies provide sufficient data on adverse effects occurring throughout the intervention period. Just 40 studies.
40 out of the 200 odd that you included.
Yeah.
So let's talk a little bit then about your findings, which you sort of broke down by exercise type. Your results showed improvements in pain, function, gait, performance, the measures that you were measuring there, including quality of life, which is interesting as well. But how did you decide what was a clinically meaningful change?
Actually, at the beginning, we included many outcomes, not just the pain, function, gain to performance, and the quality of life. Many. But finally, we just put some same thing together as a pain. And I'm a doctor. People always complain to us, I have a knee pain, I have pain here, I have pain there. So we decided pain and function, knee joint, range of motion is very important. So finally, we just put some outcome together as one. So we finally experience as pain, function, gain, and the quality of life. And people may have fear if they take aerobic exercise, they will get hurt seriously. So we check the safety.
So it's really focused on the questions that patients are asking of their clinicians in the clinic. That's what you cared about. But when you put all these findings together, what specific activities do you think might be beneficial for patients?
So from the paper, we just conclude that the aerobic exercise may be the first line for someone who had knee OA pain.
And you mentioned earlier, patients often have fears about doing some of that aerobic exercise, especially if that's some of the first exercise perhaps that they're doing. So when you looked at those 40 studies which talked about harms, did you find many harms associated with that?
Some paper just mentioned the pain severely after the exercise, but finally we calculated all the data indicating no clear evidence of difference in safety between exercise type and the control. So that's mean exercise is safe.
So that's good though, that despite some evidence of pain, that actually the exercises look like they should be safe. I don't know if this data's in there, but how does the efficacy compare to things like drug treatment and surgery or knee replacement? Where does this sit in all of the treatment options that you have?
One patient came into my outpatient room. The first choice, our recommendation must be the non-surgery choice. And I always told my patients, surgery would be my last choice to treat the knee OA. First, we told them to lose weight, education, and exercise. Before, we don't know which type of exercise, but right now, I recommend aerobic exercise. Until then, we can prescribe some drug and injection, some drug, and arthroscopy cleanings, and finally, joint replacement.
And that paper, Comparative Efficacy and Safety of Exercise Modalities in Knee Osteoarthritis, is now available on bmj.com. Links, as usual, in the podcast notes. Finally, politicians are keen on the idea of patient choice. Well, aren't we all? It's one of the medical buzzwords they love to throw around, and it's an integral part of the government's 10-year plan for the NHS in England. But at a recent meeting of the BMJ's patient panel, Munki Louis, our features editor, asked what meaningful patient choice really is.
The BMJ has an international patient and public panel, part of our commitment to having patient voices advising the journal. At a recent meeting of that panel, we wanted to get their view on the concept of patient choice. Patient choice is one of those phrases littered throughout the NHS 10-year plan. And you'll hear this being used around the world by politicians like Robert F. Kennedy Jr. But when we try and interrogate what that means, it feels increasingly hollow, like stop the boats or take back control. So we asked our panel if they felt like the concept of patient choice is meaningful anymore. Charlotte Augst, former Director of Policy, Campaigns and Improvement at Diabetes UK, started us off, talking about the NHS 10-year plan.
One of the ideas it puts forward is that consumer choice might drive up quality. Now, that is that concept of sort of consumer choice, which is individuals choosing between providers. And I tend to think, and I think the evidence would back me up on that, that doesn't really work because people can't judge the quality of providers. Clinical quality is very difficult to judge. Clinical outcomes are very difficult to understand. And the wider experience you might have with a provider is not captured in the data, whether they're rude or friendly, or whether their admin is in chaos, whether they lose your files, whether, all those things. And the kind of concept of choice that we as patient advocates in the UK have argued for is much more around the type of interaction you want to have with the healthcare system and the type of services you might want to have, and the conversation being focused on what matters to you rather than do you want to go to this hospital or this hospital, which really only works in a number of geographies anyway in the UK because there aren't little hospitals dotted all over the place. So in most places in the UK, you have a hospital you can go to. You can't go much further than that. And there's not that much of that kind of argument in the plan. One thing that they've thrown in, I don't know why at the last minute or otherwise, is this idea of sort of patient value payment, so that part of the payment a provider would get would depend on whether the patient said they had good quality care. This is a disruptive idea. I'm often up for a bit of disruption. We do bloody need it in the healthcare system, but I just think this requires some very careful thinking. I mean, we have 30% of people in this country saying we have too many migrants in this country. And if they then withhold a payment from hospital because they were treated by a black doctor, that's not helpful. We need to be also, patients go to the doctor and say, I want antibiotics, and the doctor says for very good reasons it doesn't make sense to give you antibiotics. All of that stuff, you can't drive quality healthcare really through a consumerist perspective. It needs to be much more about where you listen to. Are you well informed at the end of your treatment? Do you know what to do in a crisis? Do you know who's in charge of your care? The answers to those questions would point towards whether you had high quality care or low quality care.
Kywin Giles, co-CEO of Shine Cancer Support, echoed that sentiment and brought her own treatment choices into the discussion.
I think we need to define what we mean by patient choice. And if you look in the 10-year plan, a lot of the patient choice that gets talked about, it's patient choice about where you want to be treated. Do you want to be treated farther away or closer to home? So most people would choose closer to home. Are you going to write a review of the treatment that you got on the NHS app so everybody can see it, and then either the medical team feels bad or they feel great, depending on what you said. And I think actually if we're talking about shared decision making, then that's what we should be talking about. And we need to unpick what that means for people in terms of how you can get the best care, which is what all patients want. These choices are really often presented as binary. So you choose A or you choose B. You get treated at home or in the hospital. But actually, like, for example, for myself, I do subcutaneous immunoglobulin infusions 4 times a week at home. So that was a choice that I made during the pandemic. It's fine. But what it does mean is that I never see any other patients that have the same condition. So it's not a magic fix. Yes, I chose that it is more convenient, probably on balance, but it does have drawbacks, and there's no in between. And I think that's what we miss often, and it's the same with self-management. We talk about self-management, patient choice. They're all the kind of same slogans, but that often ends up with patients kind of being left on their own. Like, oh, you just manage your condition by yourself, and they're not sort of safety netted. And I think that's really problematic. So we need to have the nuance in it.
I think there's something else about choices and the consequences of those choices. And I'm going to make a massive assumption here, Kaiman, but when they said, here's subcutaneous immunoglobulin, they thought, oh, that's really convenient. You can take it at home. And this has been heralded as a great big step forward for patient acceptability. But actually the consequences of that were not meeting other people, not going into hospital, and losing that sort of sense of community you might have had. But you couldn't have known that then, maybe? And I think quite often in life, let alone medicine, the choices we make have consequences, and some of them we can never know. So this whole sort of patient choice agenda assumes that because it's evidence-based medicine, we can lay out, here are all the pros, here are all the cons of choice A, here are all the pros, here are all the cons of choice B, and it's up to you to balance them between you. But it never works like that. Actually, what we're talking about here with patient choice is about breaking down the power dynamic that's existed between doctors and patients, and it's actually more about making people receiving healthcare aware of their rights to ask questions, which is medical paternalism has been much talked about and much written about, and it's more about I suspect that this whole agenda is more about breaking down that power dynamic than, like you say, a binary choice of would you like treatment in this hospital or this hospital. It's just allowing people to ask questions of their treating clinician and not be told, no, you don't have a choice. So there's a kind of social agenda here, but then when it gets turned into a kind of policy, then we start turning it into these sort of binary micro level things like is it hospital A or hospital B, or is it treatment A or treatment B? And we sort of start losing the wood for the trees.
That was Henry Scowcroft, former head of communications for Alzheimer's Research UK. Our panel is international, so this isn't just about the UK. Sophia Walker is one of the BMJ's patient editors and lives in the United States. She has seen the complexity of pushing for more patient choice when that is happening within a world of misinformation.
In the US, just to give some international perspective or additional international perspective. So there's this thing with the COVID vaccine is no longer routinely given, and they're using shared decision-making as a way. So if you want the vaccine, you have to make an appointment first with a practitioner before you get it. And I kept hearing shared decision. I was like, the news was playing in the background. I was like, shared decision making, yes. And then when I heard, it was like the underbelly of shared, using it as an obstacle because you have to then, the burden of getting to the doctors, then doing that. Then anyway, I don't need to explain it to all of you. So when I saw patient choice and as it kind of rang the same alarm bells. But I also thought, I feel like I've read this document before, and I just remember with value-based health when I was in the UK, when that was a big thing, but at least this does have the patient intersection with value-based health, where I think before that was absent. So yeah, seeing kind of the negatives and the positives here.
Our last panel member on this podcast is Tamas Berecki from the European Patients Academy for Therapeutic Innovation. He brought up the issues of health literacy. For how can patients and carers make choices without an understanding of what those choices really mean?
There's one thing that we have in Germany, and I don't know whether you have that in the UK, and that is a separate state institution for health literacy and health education. It's the public institution for public health education. It's part of the Ministry of Health. They have a lot of money. Well, relatively much money. And what they do is they teach people about why vaccination is necessary. Also, it's mandatory, by the way, why it makes sense, or they will fund HIV testing sites or outreach services. They do a lot of work in women's health and helping migrants. So I think that health literacy And improving health literacy is what helps, because then people understand that they can have a choice at all.
Where does this leave us with the concept of patient choice in the NHS 10-year plan? Here's Kaiwin Giles again.
I think it's like one small part of it, but it's not everything. And actually it's touted as everything. But, looking at whether you can go to hospital A or hospital B, yes, that might be important. But actually there are probably 50 other choices you have to make along the way that are, if not more important than that initial one. And that's not what I've seen of the 10-year plan. I don't think that's included in the slogan that we see about patient choice.
That's it for this episode. We'll be back in a fortnight with more medicine and science. You can subscribe to the podcast on all major podcast apps. It's the best way to make sure you don't miss out when we release a new episode. Until then, I'm Cameron Abbasi. Thanks for listening.